and I'd like to chair this session today, abstracts this morning. We have three abstract presentations followed by a Q&A for these speakers. We then rotate around 3 more for this session. So to introduce our first speaker is Dr. James Gavin, University of Southampton, maintaining physical activity in people with long-term conditions following engagement in physical activity referral, an intervention and implementation plan. And so hopefully, if we've slides, I'll hand it over.
Thank you very much. So thank you for your time this morning, first thing on a Saturday. So I'm going to be starting off the day talking about the MOF programme. So MOF was maintenance of physical activity behaviours for people with long-term conditions. And it was funded by the Wessex NIHR Wessex ARC. So this part of it was looking at people who'd gone through exercise referral schemes, physical activity referral schemes with long-term conditions. So this is all about intervention development. Next slide. How do I? Oh, I haven't got a click. Yeah. Got it. So the purpose of this research was to identify the support needs of people with long-term conditions in maintaining physical activity. So that was after a physical activity referral team. And sorry, physical activity maintenance was the key thing that we were looking at. It's not uptaking or starting becoming physically active. It's actually going through a referral scheme and staying active afterwards. So again, in terms of why physical activity schemes, the reason we looked at those is particularly, well, in this country, the maximum you will see is 12 weeks. But for behaviour change to happen, the evidence says it's between 10 weeks above. So the minimum cut-off for behaviour change is that point where most physical activity referral schemes will be ending. So we wanted to work with people who'd been through it, but also healthcare professionals, social care professionals and others. So we wanted to, see the experiences of the people who'd been referred, but also health professionals in referring on to commissioning or supporting. So in terms of the methods, it was a qualitative study which had 3 phases. Firstly was interviews with people with long-term conditions, and that's those that had completed the PARs in the last 24 months, so within 24 months. We also then did interviews with NHS healthcare professionals who support people with long-term conditions. And then finally, we did 6 2-hour workshops. So 3 of these were people who'd been through exercise referral schemes. 3 workshops were with professionals. So with these workshops, it was more to do with convenience and availability. They weren't exclusive to NHS healthcare professionals. So we had people in the leisure industry, the voluntary community sectors as well. So in terms of, again, just going into the details of the methods, we had professional workshops with people who were responsible for the design, delivery, referral or commissioning of PARs. So we've just published the other part of this work in +1, which looked at where digital tools had been used by professionals to support people with long-term conditions, and that particularly focused on commissioners. So we also had patient and public representatives across health, social care and voluntary community services in Wessex. In terms of the semi-structured interviews and workshops, they were recorded, transcribed and analysed using thematic analysis, and we used a COM-B approach to frame the findings. So that's capability, opportunity, motivation and behaviour. Interviews, we had in total 15 with long-term conditions, and they were between 22 and 89 years old. Mostly men, so 60% of our cohort were men who were living with comorbidities, retired, and all were white British. So that told us something about who's been able to access these services. In terms of the long-term conditions, the main long-term condition that it had, we had 3 people which had musculoskeletal, 4 that were cardiovascular, 3 that were respiratory, and 5 neurological. In terms of NHS healthcare professionals, we interviewed 9 and 8 aged from 33 to 63. And we had 1 commissioner and 1 nurse, 7 GPs. In terms of the workshops, we had 6 people with long-term conditions, so they were the same people who took part across 3 workshops. And again, we did that for a particular reason. Again, it was also convenience as well and availability at the time. And we had 15 multi-sectoral professionals across the workshops. And they were in health and social care, leisure, voluntary community, social enterprise services, and PPI reps. So in terms of what we found, this is a main focus. So the experiences, people's experiences of PARS were limited accessible resources for healthcare professionals, inequitable access for the public, and that was due to cost, time and travel, and a need for better feedback and monitoring to support physical activity maintenance. That is, after they come off that referral scheme, how do we keep them active? In terms of the key overarching themes, factors influencing self-management, patients had fluctuating capability in light of aging and other symptoms like fatigue and pain. That impacted motivation. So also the key things in terms of importance was social support, goal setting and coping planning. In terms of factors supporting better partnership working between services, it was improving access to appropriate services for people with long-term conditions, to improving the delivery and support of physical activity programs. And that was from the community up. And this helped inform intervention development for us developing an integrated care pathway local to Southampton. So hopefully you can all see this. In terms of the top, on the left-hand side here, we've got the main overarching theme, number 1, which is better supported self-management. And the top 4 boxes aren't anything new. They're just a COM-B model, findings framed in that. So that's social opportunity, physical opportunity, physical capability, psychological capability, all things that we had to consider. In terms of main behaviour change techniques that we identified, goal setting and planning was key. Social support, feedback and monitoring were 2 big ones. Feedback and monitoring not just from professionals, but also from social groups. Now, second overarching theme, better partnership working between people with long-term conditions, health, social care, leisure and voluntary sectors, so multi-sectoral partnerships. In terms of improving access, we found accessible information was vital, healthy conversation trained healthcare professionals, so that's MEC training, if any of you haven't come across it, simple referral and or signposting processes. In terms of improving delivery and ongoing support, provision of ongoing support, and again, that relates to that feedback and monitoring. Evaluation of local physical activity programs. There's a national project going on at the moment with a group called Move Consultancy, who are looking at that in particular. And delivery of flexible, personalised physical activity programs for people. In terms of the conclusions of this part of the project, this exploratory study has highlighted 2 main areas for improvement to better support people with long-term conditions to stay physically active in their communities. So, number 1, multi-sectoral partnership working between people with long-term conditions, health and social care, leisure and voluntary sectors, and appropriate support with self-management for people with long-term conditions, and appropriate being personalised, social support, and also allowing things with monitoring, feedback. Potential impact. So it's generated better understanding of ways to support people with long-term conditions to maintain physical activity levels, improve health and well-being, and it's allowed us to understand people's experiences of undertaking a physical activity referral scheme to offer recommendations to help long-term condition self-management. And then finally, it's helping us to begin to develop a multi-sectoral integrated pathway. So this is something, again, that taps into people with multiple long-term conditions as well, because that's what we came across from our findings. So thank you very much. I think she sat somewhere. A lot of this work was thanks to Louisa Holt, who's a physio in our team, but also Professor Maria Stokes and Mary Barker, who's from our Faculty of Medicine, and Suzanne McDonough from the Royal College of Surgeons in Ireland. So thank you very much, and apologies for my running behind.
Thank you very much. And so on to our next speaker, Nima Ajith, Royal Borough of Kingston upon Thames, transforming musculoskeletal care and healthy ageing through community, physical and digital assets to improve health outcomes and reduce NHS demand.
Hi everyone, I'm Nima. I'm a physiotherapist in Kingston Public Health. I'm going to talk about a program that we did a few years ago during the COVID times on, everyone okay hearing? Yeah, okay. So this is a program we did over the COVID times, and it is a multi-site program. So we had me and my colleague, Lakwinder Gill from Kingston Public Health, working with Nikki Wilson, who is the consultant physio at King's College Hospital in Southwark. And we both worked with Good Boost, a company, a social enterprise that supplies the personalized exercise program using artificial intelligence. The whole project was funded by Health Innovation Network in South London. The aim of the project was not only to develop and pilot a community exercise service for people with musculoskeletal conditions or inactive adults, older adults, using the AI technology, but also to do them in non-clinical settings using non-clinical staff. Oh, sorry, it was changed. Okay. So in Southwark, it was actually people who were under the outpatients musculoskeletal service or the ones who were recently discharged from the physiotherapy service with self-management advice have been offered these exercise sessions in local leisure centre pools. They were offered up to 6 sessions. They can take up more as well. These personalized exercise programs were actually provided to them in the local pool on the pool side using the waterproof tablets. The groups of up to 8 people were supported by either the physiotherapy staff, physio students, or volunteers in the community. Participants actually met the cost of these sessions, but they did have extra refreshments like tea and coffees afterwards to kind of include a little bit of like social interaction afterwards. Yeah, the key finding after 6 months is 34 individuals actually attended this course. 28 of them were females. We actually had over half of them were from ethnic minority groups in these sessions. 35% were poor or non-swimmers, so they were not good in swimming, and 55% of the population participants were actually sedentary in their lifestyles. 40% were retired and 20% were unable to work. 3/4 actually reported enjoying these sessions. And from the quantitative data, the participants reported improvement in function, but also no change in pain or quality of life over the 6 weeks' time. Using the qualitative data, there were 2 primary things that came out. The first one was a bridge to well-being and something more than mental health, like weight management, more than musculoskeletal health, weight management, mental health options. In Kingston, it was the older adults who were isolated from different reasons, but they couldn't access the normal out classes or use the digital classes. So these individuals were identified and screened and matched with volunteers from the community, and the volunteers were trained to use the tablets so they can go into people's home to do this exercise program personalized for this individual over 12 sessions. There is a video clip. I'm not going to show it now, but you guys can look at it at your leisure there. So we had 9 participants over the 6 months that we are trialing. It was COVID time, and these were very isolated people, and majority of them had health conditions like cardiac and respiratory conditions, so we had some on and off situations there. The majority were white and retired, and 89% of them all had a sedentary lifestyle, so that's the population we're working with. They were also more at risk of falls. Almost half of them were isolated, severely lonely, lacking digital and skills and confidence. So these people actually reported the quantitative data showed improvement in pain, function between the baseline and the end of the study. Being active, digital options, health and prevention, and loneliness were the major themes that came through in the qualitative data. So to conclude, it is feasible to implement cross-sector community-based supported self-management and services that are both accessible and acceptable by both the older adults and musculoskeletal health conditions. But also we are overcoming the barriers of health inequalities and improving health outcomes. The findings were actually used for this project to continue in both these boroughs with different scale-up options, but also they were used in other sites around the country as well. So full report, any further information, you can contact us. Thank you for listening and have a good day.
Thank you very much. Our next speaker, Dr. Sarah Prenton, University of Salford. Move More, Advancing Equitable Physical Activity Provision for Greater Manchester using a co-designed whole systems approach.
Nice snappy title I've got there. I'm just going to set my own timer. I'm an academic, so I'm liable to talk too long, so I'm going to set a little timer. Right. So, what we were looking at in this part of a wider study is we're doing a study which is called the Manchester Amputation Reduction Strategy. So it's got many strands to it, and one of those is called Move More. And the aim of that is, as the name suggests, to try and increase equitable access to physical activity for people living with peripheral arterial disease. So what we know from the literature is that we know that physical activity reduces the risk of PAD, and it's within NICE guidelines, but specifically it talks about 2 hours a week for 3 months to the maximal point of pain. What we also know from the literature is the uptake of those structured exercise programs is only about 24%, so it's less than 25%. And the other thing that we know on a more local level and a more tacit level is that there are underused physical activity opportunities being offered across GM for physical activity. And so what we wanted to do was to co-design, this is very much a stakeholder, service-based stakeholder intervention, to see if we could co-design ways to integrate or embed some of those physical activities within clinical pathways. So what we did is we ran what we called Move More Summits. We had 3 of those over a number of months. We had made sure that the agendas were co-designed. We had up to 102 people, 40% of those being NHS. We also had commissioners. We had people from the leisure sector, from the VCFSE sector. And what we did in those summits is we did online surveys beforehand to prime people, to find out their opinions on things. Then we used opportunities to generate authentic conversations within those cross-sector sessions. And what we were looking for there is, what do you think are the best ways of embedding physical activity opportunities within clinical pathways? What we also did is we did semi-structured interviews with 9 individuals, again 5 of those being from the NHS, 2 commissioners, and also from Manchester Active, which is one of the leisure providers in GM, where this has already happened, to try and see if we could ascertain what the common elements of success were. All of this is embedded in an approach to research called implementation science, which is about how do you translate what works into practice. So we're not asking what, we're asking how do you do that. But underpinning that is co-design. In terms of data analysis, to try and be timely, things like thematic analysis can take a long time. Those of you who've done it will know. So we used an approach to thematic analysis called a lightning report, the Stanford lightning report method. And we also used the COM-B and behaviour change wheel to look at how that might work in terms of barriers and facilitators to embedding physical activity opportunities. For the semi-structured interviews, we've taken a more reflective thematic analysis approach. So from the summits, I'm not going to go through that, but this is an example of the COM-B, where we looked at how could we get people through the door. That's the behaviour. How do we get people to take up opportunities? But more than that, it was about trying to get this whole system group of people to coalesce around a vision. And the vision very much was around the win is for the person, not the service. And so that's what we need to all keep in mind, is that we're not gatekeeping between services. We need to try and create conditions that allow the person living with PAD to make autonomous choices around physical activity. Another thing that came out of this, almost as an aside, is that by creating this space for the whole system or people across the system to get together, they started to develop friend-based networks, which we then saw between summits were making changes in practice. And so it highlighted to us this idea of we need trust-based friendly relationships. You need to know the people around you, and you need to have the space in order for that to happen. So that was one of the key things. And obviously the other work that was going on was the semi-structured interviews. And interestingly, the same themes came out of that work. So the first theme was around team culture, and that team culture of wanting to reach out to service users and being informed by them. That's the end of my time, but I'm going to keep going. So that was a quote from them. You need to have cross-system familiarity. So you need to know what's out there. There are huge amounts of opportunities that I don't think a lot of us know about that are in our local area. And so again, it's knowing about those and investing in networks and valuing that, particularly not elitist networks, because we did find that sometimes clinicians were gatekeeping, referring into those community-based opportunities. My conclusions were, I love a bit of AI generated artwork, was that you need to get out the car and meet people. And that sounds really intuitive. We need to outreach to other system-based stakeholders, but I think that underestimates the effort that needs and the time that needs. And there needs to be what we call a change-based architecture that's built in to create that time to build those trusting relationships. And just to say that Move More is part of a wider plan. If you can spot me, it's like, where's Wally? I'm just at the back of that picture. This is the wider Mars team, and this is just the start of a programme of study. Thank you.
I'm going to say who's going to do the running. Superb. Thank you very much to our speakers. Any questions from the floor? Wait for the mic to get to you if you don't mind.
Thank you. That was really interesting with three speakers. My question's actually for Nilma. I'm really interested in your use of volunteers to support exercise in the community, and I wonder if you can tell us a little bit more about how they were selected and the risk assessment.
I mean, I obviously work in public health, and we run some exercise programs before COVID. So some of the volunteers were participants who'd done these classes before themselves. So but also we had a lot of workers, employers from different associations in Kingston who are working from home. So this was 1 hour a week for 12 weeks. So I've had council workers who's never stepped into an older people's home or know how older people live, coming back with feedback saying, oh, how great it was. I never realized how bad they could even move around in their home. The volunteers were actually selected because it was literally a pilot. So we just sent an application saying, if anyone's interested in volunteering, contact us. We did the DBS check. That's definitely done. In terms of the experience, they didn't really need anything other than being empathic to older people. If they're able to motivate them, that's even great. So it was just finding out about the volunteers and then matching them to the clients. So if they had similar interest or if they were around the same area, we kind of prioritize that so it's not too far for them to go to from their home or their workplace. So the DBS check was done. We were screening for their interest and hobbies and trying to see if we can match those around us as well. So we had a couple of tennis players joining, so different areas in terms of older people. So in terms of the training for volunteers, we did the loan working, safeguarding, all those training as part of their training. And Good Boost has a training for volunteers on how to use the app. And every time you go into the home, what to check out for in terms of the individual's abilities, but also in terms of what can they do in terms of the settings. So it was COVID time, so opening the windows up, making sure you have a distance space, mask on, gloves. So we had the PPI on as well, unfortunately, at the time through. The other training, I would say, is also to negotiate. If anything is happening, then to be able to alert. So there's always a key worker for each volunteer. If there is any emergencies, they can contact them at the time. Yeah, so it was more of safeguarding and things. And in terms of training the volunteers, it was just using the app. And some of our volunteers never used the app or about digital themselves because they were a type of person who didn't use the app. So it was a learning for them as well as learning for the clients afterwards to get them taking up digital options afterwards. Yeah. Yeah, thank you.
Thank you. There was a question just to...
Appreciated all three of those because they do, you know, I do synchronize what I find. I do two community-based Parkinson classes. Right. So my question is, the final comment I think is a really important one. Get out the car, meet people, and change a changed base architecture. So my question is, how can we make that happen?
I'm not sure. I think what it takes is, I think there needs to be a cultural shift. And a lot of projects that we see, these things are working well, and it almost underneath, there's all this other work that's gone on before, and it might be through a catalyst person who's created that space for them and their team. Sorry, I've still got timers going off. Who knows why?
For the answer.
Yeah, or the alarm going off. So I think it is about certainly collaborative leadership. It needs somebody to say, right, we need to get off this roundabout, get out of the car, create the space, hold that space for ourselves so that we can start to learn what are the opportunities, because it's always changing. It's what we refer to as a wicked problem. It's not complex. As soon as you map it, the landscape's changed. So it needs to be part of processes, embedded in processes. And I think that's a longer term aim, but I think that would be the starting point. Is you need that sort of leadership, that catalyst to say we're going to look at things differently. And that's what we found with our interviews, is that's what they did. They said we need to do something different here.
Can I jump into that? Just because in Kingston, what we have done is we have a website called Connected Kingston. Literally every single organizations, classes, clubs, whatever is happening in Kingston is put into that. So it's not just for older people, it's for adults. And for this month, we actually start something called Move Well. Before there was a gentle exercise, loneliness sections in that website. So people can go and see what are the options for them in the borough. But also they can look and say, and this goes for all the professionals. So we have really advertised to the GPs, social prescribers, physios in different departments, OTs, social workers. So everyone, all they have to do is look for that. And if someone walks in and say, I want a knitting group near me, you just look for a knitting group, put their postcode to come up with what's there for them. So it's a whole range of activities. So I think having a central thing, and each of us have the ownership of changing our details in there. And we always tell clients as well, if you know of a club that's not there, ask them to put it on. So
Is that run by the local authority?
Yes, yeah.
There are similar things in GM, for example. I think the key thing I just add to that is it's not just about signposting. No. You have to get to know the people, because then if you trust the person, your clients or service users, they see that.
Just adding on to that as well, it goes back to the people, because we've got Hampshire and Isle of Wight have got a similar repository, and we keep hearing that people want to repository, but that's the people who can access digital. Yeah. People also want community groups, and we've been doing community cafes, kind of knowledge exchange from the back of this, and it's both ways. So it's not just having something online, because ultimately that needs managing. And not everyone's going to get access.
I think
really
for our non-digital clients, all the library staff are trained in using that. And also there's lots of community champions who knows how to use them from different clubs. So again, even the non-digital can access it through another person kind of thing. So we always say, if you can't access digital, just ask one of the library staff. And there's about 6 different libraries in Kingston. So, you just have to jump into one of those through.
A big one, sorry, last thing, but it's fine, no, sorry. The other big one as well, our local football club, the charity side of them, Saints Foundation, are fantastic, and a lot of people know what they do in the city. And they have, I think, they have the funding, but they have 2 exercise sessions a day. This is all over the city of Southampton, but they're sort of fantastic. It's chair-based exercise to walking groups, Friday social, and those sort of groups are really kind of really supportive of sort of the local communities, of getting people together.
Thank you. And any other questions from the floor?
Can I ask, you mentioned implementation science, which I haven't heard of before. Could you
Yes.
say a little bit more about that? I was involved in a nursing home trial, or the beginnings of a trial, and the problem seemed to be that we got hung up in trying to prove what's been proved
Yes.
before, rather than say, okay, well, these are the things, but are they being put in? Anyway, if you could tell me about it, that'd be great to hear.
So implementation science is based on the notion that we have things that we know that work, that have efficacy and effectiveness studies already done on them. But the problem is that they're often done under very controlled conditions. And so what they look like in the research space is not the same as what it looks like in reality. And that's why we see it can take 17 years for things to get into practice at a 50-50 rate. That's the sort of figures. So implementation science says that you work through a process of trying to figure out what the determinants are that would indicate whether something might be implementable. You think about implementation outcomes, so you start to look at things like fidelity. Can we tweak it and it still work? So for example, with PAD, if it's 2 hours a week, would 1 hour be enough? Because that's what people are doing in reality. We can't offer 2 hours, so we'll offer 1 hour. But according to the efficacy literature, that isn't correct. So this is what it's looking at. So we use a process model called the knowledge to action model. And within that, then you can use various models within that. So we use COMBI and something called CIFA, which is looking at the determinants. It draws on a lot of qualitative data, so it's a mixed methods approach, but you're looking at not efficacy outcomes, but in some ways you might be, but often implementation outcomes, so acceptability, sustainability, scalability, fidelity, etc.
Helps reduce a lot of wastage as well, because if you think someone wins a £500,000 grant, does that always go actually into practice? A lot of the times it doesn't. So again, implementation just supports that. They actually change in practice.
Any more hands?
Sorry. So the situation with nursing homes, the situation as far as getting more physical activity is really extreme. It's bad enough in people's homes and bad enough when people have got self-efficacy. But where people require support from the people who are caring for them to appreciate and get them more active, and it seems to me it's very much it's within our remit as physios. We know that this works, but people in the nursing home working as carers and working as physios don't know it and have difficulty, and it just doesn't get applied. In fact, people are kept in bed so they don't fall over, aren't they?
I would just start off by saying that it's also about differentiating what we mean by physical activity and exercise. Exercise is a form of physical activity, but physical activity needs to be embedded throughout the day. So there are programs that can be used around workforce development to help people to see that this is an important care need. But appreciating, again, a lot of research isn't done in care homes. And it's a very different culture within care homes. So part of that is learning what that is, learning what the barriers and facilitators might be, and working with the workforce.
Yeah, I think we got a couple of options in the nursing homes happening. Kingston and Richmond is doing, they have a physio who's kind of like doing this activity, training the staff in the nursing homes. But also the local Leisure Centre in Kingston is actually going into homes, nursing homes and residential homes, and doing some activity, some exercise programs through it. So those are two initiatives that are happening at the moment. So we might find more as things go through.
Any further questions from the floor? I have one regarding partnerships, if that's okay. I know that Good Boost was mentioned as a social enterprise, and then in the discussion, Southampton Football Club, I assume, are running some of the schemes that you're describing. How have your experiences been linking with those sort of third parties?
I have to say it's been quite good. With Good Boost and stuff, it's quite easy sailing, and because it's funded through the HIN network as well, so it was kind of going through with them, and they were able to, because it used to be a musculoskeletal hydrotherapy app, So when we said we want it for the older people, they were able to kind of do the programs on balance and stuff to kind of match the needs of the people as well. And in terms of the questions we are asking and stuff as well, quantitative data and stuff. So it was kind of done, and the training was already within their module kind of thing, but we just had to do it for the lab and app. So a lot of companies are quite good. And in terms of the local opportunities, lesser centers and stuff, they're always looking for opportunities to get more people in. So we are kind of saying, well, when they go to these exercise programs, swimming pool, they don't just go and come, they kind of stay in the cafe, they kind of spend more money in there. And Southwark, they were actually paying for the things as well. So I think it was £5 something or something. So they were literally the clients. So they had extra people coming into their doors who wouldn't have normally come through. So I think partnership worked quite well for us, just because in terms of the initiating part, in terms of some of the lesser centers at the moment, we are kind of done one project with the swimming pool in Kingston, another one. So sometimes the starting point is the hardest, because they are kind of like worried how much staffing they need in terms of doing things. But the first few sessions, we have the one staff over 10 people. This was the second part of the study, literally keeping an eye on them being able to do the digital side. But the second half, people were going themselves and doing the digital side themselves. So it is kind of saying all we need is one staff and a reception staff to give their tablets to the clients until they get used to. So it's just kind of like negotiating what's the need, how much of the pool space that you need. We were literally taking one lane of the pool rather than the whole pool. So we didn't take off the pool time from someone else, kind of thing, yeah. Yes.
Thank you.
And likewise, it's really easy. It's just offering them something, because a lot of, again, we're all strapped for cash at the moment. And one of the nice things being an academic, you can go to the likes of Saints Foundation or our one's Active Nation, who run the leisure centres, and they've just got Good Boost. And I've not used it yet, but I want to go and see it. But similar thing, you come with them to say, look, you're using you've got the schemes running. What do you need support with? And that way you can kind of have those conversations. But it's a little gestures, because it's starting small and saying there's a £5,000 grant that's come up, and again that leads you on to more work. But it's just having patience, because like everyone else, they're busy and
and a lot of lesser centers and stuff have these sociable fund that they are supposed to spend on social things, or charitable things that they have to meet. So you kind of tap into those as well. So just kind of like saying Nuffield, we were at Kingston for the second part of the swimming program. We were running it in Nuffield, and they have a particular fund separately for the well-being scenario for people who wouldn't normally access Nuffield. So it was and they actually did it free of charge. So we were doing it.
Sorry,
Just very quickly,
Yeah, but
in
it will need to be.
GM Active, the leisure sector was the ones who initiated this. They're trying to pivot to more of a wellness and health space.
Super. I mean, that's
So
been
we've just been facilitating them to make those links. They were the catalyst.
great. That's been my experience locally as well. And decentralising and demedicalising, we've known, has been suggested for many years, but difficult to do the doing. So thank you very much for your work. And could you give a round of applause for our first three speakers?
thank you, Doug.
I'd like to welcome our next three speakers onto stage, please. Our first speaker of this next session is the implementation of, Dr. Esther Williamson, University of Exeter, the implementation of a physical and psychological group physiotherapy intervention for older people with spinal stenosis.
Thank you. Good morning. Thank you for the opportunity to speak today. Talking about implementation again. So that was a really nice description that we got from Sarah there about implementation. So thank you for that. So I'm presenting on behalf of the Boost implementation team. This work has been funded by the National Institute of Health Research. So our project is looking at the implementation of a group physical and psychological program for older people with spinal stenosis. Spinal stenosis is a really disabling condition for older people. It particularly affects their ability to walk. They get pain in their back radiating down into their legs. It's that typical picture, which I'm sure you're all familiar with, about pain that's provoked with standing and walking and then made better by sitting and bending. And it is the most common reason that older people will go for spinal surgery. And the treatments that we have to date aren't particularly effective. Often things like medication don't particularly help, but they also have side effects, putting older people at risk of falls. So there was really a need to provide effective rehabilitation. And this was the landscape in which we undertook this initial study that I'll tell you about. So we had a program grant in which we developed the BOOST program, and we then went on to test it in a large clinical trial. So this was done at the University of Oxford. It took about 4 years. We had 438 participants. And what we found was that participants who attended the BOOST program improved their walking and physical performance, both at 6 months and 12 months. We also had a 40% reduction in falls risk, which was actually a really good outcome and something we hadn't particularly expected. And it also then improved pain-related disability at 6 months. It was also shown to be good value for the NHS to deliver this program. So the BOOST program was a 12-week program. Everyone attended for an initial assessment where they were given their exercises. So the exercises done in the group was tailored to the individual in terms of the load and the reps and the sort of progressions that they did. Each group followed the same format. There was a group discussion which focused on pain management, self-management, encouraging physical activity, and particularly looking at how we got people to continue to exercise in the long term. They then did their exercise circuit, which was tailored to each individual. It included strengthening exercises, a stretch, and a series of balance exercises. And then there was a supervised element of walking element where they actually went walking with the physio, really aimed at building confidence and endurance in their walking. So that was the original BOOST program. When we finished the trial, we were given the opportunity to apply for a small pot of money to look at implementation, really to see how we could look at getting this program that we tested in a clinical trial into clinical practice. So we were able to undertake the BOOST implementation study. So this was a 2-stage study. So in the first stage, we had the opportunity to try and optimize the BOOST program. So some of the outcomes that we got in the trial were good, but others we thought we could improve upon, particularly looking at, we hoped we could improve pain-related disability. And we also wanted to see how we needed to tweak the program for implementation. So like Sarah was saying earlier, that things often done in clinical trials, you know, we need to make sure they can translate into the real world. So the first stage was doing the optimization, then evaluating it. And then the second stage, we wanted to look at how we could scale up training. So we trained people face-to-face in the trial, and we did in stage 1, but we needed to see how we could make this available on a much wider scale and then go on to evaluate that as well. So the theoretical framework that underpinned this work was the IPARIS implementation framework. There's lots of different frameworks you can use for implementation, but this particular framework looks at how you try to get an innovation into a new setting. So translation here was the innovation was the BOOST program, and we were trying to get it into routine care. And we needed to look at the recipients, the context, and then what were possible facilitators. So in stage 1, we undertook what we called optimization. And this included looking at the trial data to see where we could target the intervention better, to see if we could get better outcomes. So one of the activities that we noticed really didn't change for people from their data was standing. So this was then one of the focuses of the intervention. And then we also formed a community of practice where we worked with patients who had attended the BOOST program in the trial, physios who had delivered the program, managers, and also a clinical pharmacist. On the back of the optimization, we then trained up 6 therapists and 1 exercise instructor to deliver the optimized program, and we measured outcomes then for their patients. We then undertook what we call a synthetic control. So this is basically using data from the main trial to make comparisons with the data that we collect in this new study, and then interviews with clinicians were also undertaken. Stage 2, we then developed the online training on the basis of what we learned in stage 1. We invited physios to do the training and to complete outcomes, and then we asked them to also deliver the program in clinical practice, and we collected more outcomes, once again using then the synthetic control method to compare the results with the trial. And we also talked to clinicians. So in terms of optimization, what did we change? Well, in the original program, the program was actually front-loaded. So we started off with 2 times a week, then we went down to once a week, and then once a fortnight. But actually, the physios couldn't operationalize this in the NHS. Their diaries didn't like the fact that we changed how many sessions there were a week. So we actually changed it to once a week delivery. We talked more about post-group exercise plans earlier in the program to try and really get that translation to behavior change beyond the program. So exactly what our previous speakers were talking about. And one of the concerns of the patients was that when they went to join an exercise class, if they had a health condition, sometimes people were reluctant to let them join. So they came up with the idea of some little business cards that kind of explained their condition and any advice around what they could do around exercise that they could take. We streamlined some of the educational content, including adding a video about medication use. And then we refined some of the exercises as well, based on feedback from the physios, adding in 2 exercises, targeting standing and lifting. We then developed the online course as well, and this is just some screenshots from the course. So with the training outcomes, we aimed to enroll 31 physios in the course to begin with, to do some evaluation. We had 31 enroll and 77% completed it. So this was essentially a free course for them to sign up and do online. Everyone was satisfied with the training and felt that it provided the skills they needed to deliver the program in clinical practice. And most of them said they were planning to implement it. At 6 months, we then got feedback from around 60% of the people who did the training, and around 2/3 were delivering the program at that point, and another 22% were actually, although they couldn't deliver the program, they were using elements of the training in their practice. So in terms of clinical outcomes, at stage 1, we had the program delivered at 4 sites. 31 participants were enrolled in the program, and we got follow-up data from 84%. Stage 2, we had 9 sites, 74 participants, and again, follow-up around 80%. In stage 1, one of the sites that delivered the program actually was a partnership between physios and active leads. So just kind of going back to some of those conversations we've had earlier about making links with the community sectors as well. So when we look at the outcomes then, the main column to look at there is the blue table. And this is the differences in the primary outcomes that we'd set for this study. So on the left in white is the difference in the trial between the 2 groups. And what we actually found with the optimized program was we had around 3 times the difference in improvement in walking. We had similar, well, slightly better on the ODI walking item, and improvements also in the ODI total compared to the main trial. So we were really pleased with those outcomes, that actually it looked like optimization of the program had improved our clinical outcomes. We talked to participants, and this is the sort of some of the examples of some of the quotes for the interview. But what came out from talking to patients was that impact wasn't only physical, it was also psychological. And obviously that was the point of the program, was it was a physical and psychological program, but they talked about, you know, that they hadn't expected these improvements. I think there's one there about both mind and mobility were much better. And then I think that last quote at the end there is really summing up what the program was about being an enabler for an active life. We spoke to the physios, and actually similar themes came out of the interviews with them about them seeing not only the physical improvement, but also particularly they noted improvement in confidence was what they noted as a result of the program. So in conclusion, the study demonstrated successful implementation of the BOOST program into routine practice. We could train the physios up using the online program to deliver it effectively. And the clinical outcomes that we achieved during the study suggested that optimization was worthwhile. So the training is now available for people to do free of charge. It was on the Future Learn platform, and it's now moved to the Exeter Learn platform. So this QR code will take you to the landing page at Exeter University, where all the courses that we provide free of charge for health professionals are listed. There's the QR code again, but if anyone has any questions, then please feel free to contact me. Thank you.
Thank you. Our next speaker is Dr. Rachel Chester, University of East Anglia. Behaviour change techniques to promote self-management for people attending physiotherapy with musculoskeletal conditions, a scoping review and mapping exercise.
Yes, thank you.
Thank you.
and thanks to the team on whose behalf I'm presenting this. My name's Rachel Chester. I work at the University of East Anglia. I'd just like to start to, oops, thank you. This is the team. Carl's here somewhere, but I think he might have gone to another session. He's heard it before. But also thank you to the MACP, who awarded an Elsevier Research Award to carry out this work. A little bit about the background. We know that exercise or physical activity is an effective intervention for musculoskeletal problems. And we know that self-management is as well. But many things can get in the way and help as well. And these are called barriers and facilitators. Behaviour change techniques are any part of an intervention that promotes behaviour change. And the behaviour change taxonomy, written by psychologists, contains 93 of those. But we know from others' research that physiotherapists only use 6 of these in observational studies, irrespective of what barriers and facilitators their patient has, because of course they'll be different for different patients. They just generally use 6, or we generally use 6. I obviously include myself in that. So the purpose of our study was to identify the barriers and facilitators of home exercise and self-management that have got some evidence in the literature, primary literature. We wanted then to map these to psychological or behaviour change frameworks, and then provide examples of behaviour change techniques, or BCTs as they're called, to use in clinical practice. Our ultimate aim, this is the very beginning of the research pathway, but our ultimate aim is when a physiotherapist comes in, they're able to assess the barriers and facilitators, of which there are probably hundreds, that are important to that particular patient in terms of getting in the way or facilitating their home exercises or self-management, and then to be able to use the behaviour change techniques that target those. So be more selective in that. So first of all, we carried out a scoping review to identify the barriers and facilitators that had some evidence in at least 2 articles. We then mapped these to 2 behaviour change or psychological frameworks. And this is the one colleagues here have talked about a little bit earlier. It's called the COMBI. And really we can map any barrier and facilitator to 3 different categories: either capability, opportunity, or motivation. And in turn, those can be broken down into, for example, is it psychological or is it physical capability? Now, for this exercise, we used a slightly more complex behaviour change model called the Theoretical Domains Framework, or the TDF. This allows us to categorise behaviour change techniques and then map them to evidence-based BCTs using something called the Theory and Techniques tools. This is a well-established tool developed by psychologists for any form of behaviour change. And here's just a snippet. You can see along the top there's all the different TDF categories to which we'll have mapped our barrier or facilitator: knowledge, skills, beliefs about capabilities. And then in the rows, we've got all 93 behaviour change techniques. Then you map them and you can see the different coloured boxes will show the evidence from all the literature for any behaviour change, of whether that's, there's evidence, strong evidence, inconsistent evidence, and so on. So what did we find? Well, we found 28 studies with over 5,000 participants. And we found that the key barriers and facilitators, there were 3. Overwhelming evidence compared with any others was exercise self-efficacy, so confidence in their ability to do the exercises. This was followed by social support, whether it was present or not. So these could be a barrier or facilitator, depending on their absence or not, and task appreciation. And by task appreciation, that's an action by the physio showing that they understand really the challenge of carrying out self-management and home exercises at home. It's no easy task. Then, showing the theory and techniques tools that we showed earlier, we mapped these to 7 of the 14 TDF categories. And that allowed us then to look at the BCTs. And the most common BCT that we identified was problem solving. And problem solving was one of the 6 that wasn't used by physiotherapists in others literature. So that's a new one for us that we can perhaps integrate a lot more into our practice. And also, of course, one that we all use, I expect, instructions on how to perform the behaviour, i.e. how to perform the exercises or the self-management advice. So, from our paper, this is an infogram that we designed to try and show how you can implement this into clinical practice. The illustration designed by Carl. I'm just going to take one example. You can see 2 over there. And this is just an example. It's to show how familiar, despite all this science that might be new to you, is familiar probably some of the techniques when we bring it back to the practice. Physiotherapist encourages Bob to palpate his thigh muscles during his exercises to feel them working. And in terms of the behaviour change taxonomy, which was a 93, this is called biofeedback. So when you get full cycle back, you'll find that a lot of these things are things that we're using already. Yeah, but it's just that we can probably target them perhaps more effectively. For some patients, there's no point giving them lots of confidence and further instructions if they're already really confident, but they just haven't got the time. We need to make sure that we choose the BCTs that are most relevant. So if you want to find out a little bit more, please have a look at our article where the full infogram is. And also in our part, I think it was really helpful, but thank you to the previous speakers talking about implementation. What we've started to do now is we've developed a free online course with Future Learn. It's about managing 2 of these barriers and facilitators: patient expectation and pain self-efficacy for musculoskeletal conditions. It really explains how you might assess and how you might integrate them into standard assessment and management without having to change your time. And finally, really about implementation, we're developing a course of physiotherapists funded by a postdoctoral research fellowship, integrating change conversations into physiotherapy consultations. Thank you. There we are.
Thank you. Our final speaker of this session is Michelle Thirlwell, East Lancashire Hospitals NHS Trust. Barriers and facilitators to exercise engagement in people over 60 at risk of falls, an exploratory study.
Right, so hi, my name is Michelle Thirlwell. I'm an MSK clinical specialist physio. I'm based at ELHT. I'm also a principal investigator based with NIHR. So firstly, I was with ARC, and now I've moved to the scholarship with CRN. Let's move on. This is my poster. There's a link at the end. If you want to access that online, you can do. As it's just been discussed, my project is the barriers and facilitators to exercise engagement in people over 60. Looking at my slide, this is just to tell you a little bit about our patient journey, a bit of the background of what I'm doing and why. So there's 3 referrals with this Mrs. M, who is from Blackburn. So 3 referrals into the service with falls, or 3 very different injuries and MSK pathologies that we all currently treat. Progressively, mum immobile, there was COVID, smack bang in the middle of this, it deconditioned this lady. Obviously, this is a common presentation. And commonly across all 3 of these referrals, although obviously physio management, we all do a really great job, the adherence is unknown. So did the patient comply or adhere to engage in what the physio advice and exercises were given? And also, even if they did engage, we don't really know the outcome. So the use of the outcome measures with each referral. So I guess what I'm trying to say is, linking with what all the guys have said here about the behaviour change, what do the patients actually think? So from a patient perspective, what is the purpose of physio? So essentially what I've just talked about there is the revolving door. So this is the gap here, looking at returning of patients into our service. Obviously it's costly, deals with extra waiting lists, costs with DNAs, and then the clinical need here. Obviously 35% of our caseload in ELHT and MSK is over the age of 60. The costs, we know, are expensive, both in terms of falls and fractures and immobility. It's 7 billion for immobility. And there's obviously above average A&E attendances in the Northwest. And that's for falls, fractures, soft tissue injuries. So the gap that I found a few years ago was a lack of research addressing the reasons for exercise and physio adherence and outcomes in the over 60s, particularly in the Northwest area. And looking at health inequalities. There is a bit more evidence now, but looking at the methods, so I have gone through ethics and I've done 10 interviews, semi-structured interviews of patient perspectives. In terms of the eligibility, I created an EMIS template and got staff at my Rosendale site to help me recruit these patients. Okay, so looking at the results, obviously the results will be available in depth once I've published if you want to know a bit more. But for now, patients are between 60 and 90 years old, all have varied pathologies, transcribed, the data's been transcribed with obviously in vivo, looking at the COMBI behaviour model. And some of these questions that I asked are up on the screen now. So what is exercise? What does it mean? What is your understanding of physio? How can we improve on our exercise and advice that we give you? And looking at these themes coming through on the service and tools we use, literature and website information. So, conclusion. So the challenge is many reasons why patients obviously don't adhere. We know that there's lots of reasons for that. There are possibilities that adherence could be higher if it's seen important to the patient. So using the shared decision-making model, they could self-progress and regress a little more so they have the control and that self-efficacy that we just talked about. Less information, but more efficient, looking at time and habits and what we're doing in clinic to make our service that we provide more quality and more efficient. So my next aim is looking at this really. What does physio adherence impact outcomes in patients? So I'm looking at those underserved populations. So this is, my final slide. So here we've got I'm going to be publishing, disseminating the information, hopefully within the next 6 months. And then I'm going to look at community engagement and co-design. So how can we implement the changes I've found using the PPI in underserved communities, looking at a behaviour change intervention and evaluating the physio adherence with an outcome measure to improve what we're delivering in service, and then the funding that I'm going to look in for that. So if there's any questions or you want to collaborate or any further details, you can get in touch with some of my Twitter handles here. And then there's a link there which links to my NIHR profile. Thank you.
Okay, thank you very much to our speakers. Any questions from the floor? We've got a roaming mic again.
Thank you to everyone for that. That was really interesting. I've got a question specifically for Astor Wilson about if you were to do this project again, would you do anything differently? Like I'm thinking of the fact that there was a full randomized control trial done first and then a whole other implementation trial. Would there be a way that you could shorten things down and have the implementation as part of setting up the initial trial? How feasible do you think that might be?
Yeah, no, that's a good question. I mean, I guess there are trial designs where you do that kind of hybrid clinical effectiveness implementation trial. And I guess when we designed this study, which was about 10 years ago, we weren't really probably so much in that space, if I'm honest, so that wasn't kind of on our agenda, really. I think that we've learnt a lot since we started this work. There was a program grant. We had 2 years of applying for funds and then 6 years of doing it. So we're talking 10 years of work now since all of that started. So I think definitely applications I'm involved at the moment are much more going down that route where we're looking at both clinical effectiveness, cost effectiveness evaluation alongside the implementation outcomes as well. But I think there is something about when all the kind of big research finishes about putting it into practice still that needs to be done. So I think there is always going to be that bit on the end still, even if you did that during the main trial.
Thank you. Any more questions from the floor? There's one at the back there.
It was just a question for Esther again. So we were part of the Boost implementation study and it went really, really well and we've implemented it at work. And I was wondering what your success rate was and how many people have managed to carry it on after the implementation study finished.
I actually don't know that, Becky, off the top of my head. I mean, Cynthia did the interviews and we talked about sites that were in the process of trying to get it into practice and getting it funded. So there were issues around it being a kind of, you know, new service to be delivered, and actually not all sites were able to then continue it after the study. And I think that's the real shame, is that when we do things and we show they work, actually there's that short-sightedness in terms of kind of management, that actually that lack of investment in rehab, I think, is quite often demonstrated in these situations. So while we were supporting them and it was part of the implementation study, they were able to deliver it, but then it's not always clear what happens after that. And there is a point where we have to let go and let people, you know, it's out there, it's a resource, and departments have to decide to use it. We can give them the evidence and tell them it's cost effectiveness and give them the tools, but actually it then needs to be let free, I guess, to actually become more organic. And people may, so some sites may have tweaked it a bit then to make it more suitable for their service, and that kind of natural evolution perhaps of the program happens in real life.
Hi, I'm Sharon. Thank you for the presentation. I have a background in delivering physical and psychological elements of program, and I've also done a doctorate research on this area. My questions is always about, we know patients have poor adherence to self-management and exercise, and behavioral change is important, but how can we educate our workforce or next generation in terms of bridge that gap between clinical and education? How can we help the more physio to have those skills to be able to understand, assess the barriers and enablers of behavioral change?
Funnily enough, that's what my postdoctoral fellowship, the CSP, obviously recognised that as an important question, and that's really what we're doing. So that first part of our research was, I suppose, to get the science, and I think a lot of the barriers and facilitators we've identified won't be surprises to people. It's more perhaps the BCTs, but there's so many that we could use at our disposal. And so really our next part is, we do integrate it in our pre-registration curriculum anyway, as then I can see, you know, all the academic colleagues, I think we all do, don't we? We all integrate it. And I think it's then practicing it. But what we're trying to do with this piece of research is try to do a training programme for post-registration physiotherapists who might not have done it, and also some tools that can assist them in the clinic. So, for example, it might be that, I'm just making, you know, an example, a patient might fill in a questionnaire, that identifies the common barriers and facilitators for them, and then we're hoping to do an algorithm that then links to the BCTs that would be useful for that particular barrier or facilitator. And, you know, and at the other end, we'd have a short thing. Dear Bob, it sounds like, you know, you really want to engage with your exercises, but you're a little bit frightened that they might aggravate your symptoms. Or dear Anne, thanks for the questionnaire. It sounds like you're really busy. How can we help you to prioritise the time and fit it in your day? So those are just some examples, if you like. But I think there's lots of people on the case.
Yeah, and I also think there's those systems changes that we were talking about with the previous speakers around, you know, there's so much, you know, you could have, the patient can be very well intentioned that they're going to do this, but then there's nowhere for them to go and do it. You know, so actually it's not just about us implementing behaviour change in the clinic. It's, I think, about that whole system approach and joined up. About, you know, the COM-B opportunity is one of the factors, isn't it? So actually around providing lots of opportunity for people as well to put those intentions into practice.
I'll just add to that as well. I think there's lots of things that have come out. There are similar ones between the patients, but in a day-to-day clinical environment, it's something that we can use very efficiently and sort of standardised across all of our physio staff that we can still tailor to patients. So I know that I have ideas off the back of what I've just done. And I think we've already talked about linking up together to try and see where we can go next with it.
Hi. So I just had a question for the two of you that have developed training off the back of the work that you've done. For me, it might be a slightly existential question because training is a behaviour change intervention. So in terms of long-term sustainability of staff taking up that opportunity, have you thought about what other behaviour change techniques you might wrap around that training to enable staff to be able to access that? If that makes sense? Because online training, we all have huge amounts of online training we could do, we should do. So how are you maybe priming staff to see this in the big sort of sea of all the other things that they're probably being asked to do?
I suppose ours was just the first. It was a quick, cheapy type thing, minimal funding, you can do something on Future Learn. But it's really changing the culture, isn't it? And right from pre-registration, integrating it. You're doing your objective assessment. We're not just looking now for what's wrong. We're telling the patient as we're going along, oh, what do you think of your range of movement? Well, actually, that's pretty good. Yes, it is. You've got great. There's nothing wrong with the joint, is it? What do you think's going on here? So the patients, we know, shared decision making, but also to use that, I'm using it as an example when we teach the pre-reg, that objective assessment is also about building the patient's self-efficacy for what they can do, and it's also about showing them and making those links between their goals and the exercises, so on. So I suppose it's integrating it from an early stage, but also I think, as you're doing as well, getting patients on board and clinicians on board, so they're driving how they integrate it into their departments. Very much so. So I think both, back to yourself, very much is from a bottom-up approach as well.
Michelle, I just wondered if you had a strong sense of how translatable some of this and it would apply across the projects would be across postcodes, the specifics under people's demographic circumstances and other community-related factors. Sometimes we're always hoping for a template that can be moved, but also something that has that enough flex to actually then tailor it to an individual location. I just wondered if you'd had any sort of strong sense from your data as to whether that's something you can work on.
So like other interviews, it's primarily white British who have been recruited to these, but we do a lot of community engagement events around Blackburn, Burnley area from a research perspective. So we are getting many sort of opinions and thoughts from those from underserved communities, and obviously those that are over the age of 60-65 are also considered of looking at the health inequalities there in terms of eligibility, literacy, which we talked about looking previously on websites and things. But I think some of the results from my interview will address some of that in terms of any information leaflets or any sort of things we can do to improve patients' access to the service, and also looking at the information we provide to them. But it has to be simple, and obviously this is all about adherence and looking at behaviour change, but actually at the end of the day, does it influence their journey? Does it influence their outcomes? And that's the thing that we shouldn't really forget, because they can adhere, but does it actually, what does it improve them and what they want? So I think it's really looking at that individual, which is obviously lacking in the Northwest. So hopefully we'll be able to work on something that is translatable and can be used with our populations.
Thank you. Any other questions from the floor?
I'm going to go back to the trainers again as well. Just wondering, because I know the training was devised for physiotherapists, but can other professionals involved in the exercise, like the lesser center staff, use the training as well? Because it just makes sense for it to kind of carry on in terms of.
Can I say something about that? Yeah, so that's one of the things we're actually quite interested in is looking at how we might broaden access by looking at alternative models of delivery as well. So we did sort of a trial run of that in our study where we partnered Leeds Community Trust partnered with Active Leeds, and the Leeds Community Trust identified the patients, did the initial assessment, and then they actually went to the leisure centre where they had the program delivered by an exercise trainer. And the physio was a link. So the physio came out, I think, halfway through the program just to check in with people and see how they were getting on. And then they did a phone call with them at the end. But essentially, it was delivered by the exercise trainer, and it went really well. In fact, the patients absolutely loved it, and they loved getting out of the NHS setting and into the gym. And one of the reasons we kind of looked at that was lack of capacity within the NHS Trust to deliver it. But also that idea that the person running the class actually then ran other classes. So they could say to them on finishing it, well, actually, you could come to my strength class or you could come to this. And that was one of the ideas really to trying to get that kind of follow through afterwards as well. So that's actually one of the things that I particularly am interested in, how we do better partnerships between physiotherapy and clinical services and these types of community providers to get things much more embedded in community going forward for long-term adherence and participation.
There is something, just to add to that, there is something called the asset-based approach that's using like members of the community or leaders of a community to help get patients on board, particularly those who may not speak our primary language. But I think it is keeping it simple. So little simple questions like, what is physio? What does it actually mean to you? The results and the answers are quite surprising. So I think it's not forgetting those populations who have more, we don't want the health inequalities, so trying to make it a little bit more equal.
We have time for one more question, if you have it from the floor. Oh, we can wrap up at that then, yep.
Yeah, just to endorse what Michelle just said, that the international organisations have got a lot of experience in creating culture changes within community, and my particular experience was in where I worked in Bangladesh, changes in attitude and experiencing leprosy services. So they targeted all the community. Before they targeted the patient, they targeted all the community influencers. And then that was the message coming to the patients from many sources. So it really is what you were really saying, you know. Thank you.
So thank you. And so, yeah, that cultural competence that we all need to make sure we're aware of speaks to how we might translate this across communities. Also, what might be useful for the professional brand of physiotherapy might be great that people feel confident and comfortable training and working with us. But if we want these things to stand the test of time beyond trials and even implementation trials, we might need to link in with personal trainers and other gym providers in ways that mean that we do end up having to be brave enough to deprofessionalise it. And that can be strange, really, with our relationship. Now, how much are our clinical skills essential to the product once it's in a ready state, and something for all to reflect on. Thank you so much for the work that's been done. Can we give a round of applause to our speakers? And a final word from me for those around lunchtime. Please do be aware it is our CSP AGM. I accept, of course, that these are sometimes dry affairs where there's some numbers need to be presented to you, but it is an opportunity for us to improve our member engagement, especially now that we are back in person. And so if you do have a bit of time to pop by the AGM, I think it's at 12:30, then it would be much appreciated. Thank you.
You too. Thank you. Wasn't it that I liked the variation?